Welcome to this Peer Voice activity. To access the entire activity, including supporting material, go to www.peervoice.com/SDC. This activity is supported by an unrestricted educational grant from AstraZeneca.
Hi, I'm Professor Syed Hussain from University of Sheffield in United Kingdom. Welcome to the peer-to-peer discussion on the use of immune checkpoint inhibitors in earlier stages of bladder cancer. The bladder cancer field is evolving and the landscape is changing. Today, I'm delighted that I'm joined by my colleagues Brenda Martoni, an oncology practitioner at Northwestern Medicine in the US, and my colleague Diane Leach, a uro-oncology nurse practitioner at Western Park Hospital in UK. I think what is really exciting is that how the field has evolved over the last decade. We have seen immune checkpoint inhibitors moving from metastatic urothelial cancers to perioperative settings and having a big impact on outcomes. We had seen a subset of patients in second-line treatment in metastatic urothelial cancer with immune checkpoint inhibitors having a long-term benefits as well. And moving it to earlier disease setting in the maintenance setting, we saw the benefit. And now we are delighted to see that this is moving into perioperative setting. And I think as this moves in towards perioperative setting, in earlier disease setting, it is really important that we are involving our urology colleagues, urology nurses, who are part and parcel of this multidisciplinary team to get the best treatment option for our patients and improve the outcomes, both in terms of disease-free survival and overall survival. So, Brenda, as an oncology nurse with extensive experience in immune checkpoint inhibitors, could you walk us through the mechanism of action of these agents and explain how they help restore anti-tumor immune responses and how the same mechanism can lead to immune-mediated adverse events?
I would be delighted. So, checkpoint proteins, PD-1, PD-L1, prevent excessive immune activation, and they protect us from autoimmunity. So, these neutrophils, all those different white cells know what's self versus what's not. Unfortunately, tumors can exploit this PD-L1 expression. They can bind to the PD-1, and that leads to T cell inactivation, preventing tumor cell death. A lot of patients will ask me, well, shouldn't my immune system be recognizing what is itself and what's cancer? And when I explain how this mechanism works, they're like, oh, I get it. So how can we reactivate our immune system, kind of uncloak the cancer and get our immune system fighting the cancer cells? So if we can block the binding of the PD-L1 to PD-1 with an ICI or immune checkpoint inhibitor, this enables T cell reactivation, favoring anti-tumor immunity. Unfortunately, there are times when the immune system may not recognize self when this activation, T cell activation occurs. And so there is the possibility of developing an inflammatory sort of reaction in any part of the body. So basically, the immune cells, they are activated. And so this can lead to some unique toxicities that aren't associated with some of our intravesical therapies or some of our other chemotherapies. And so what I tell patients is what they're not supposed to feel. So basically, when we go through the side effects, if they're having any sort of inflammation in their body, they should definitely let us know. And this effect doesn't always occur immediately. It's something that can occur months and months after treatment and requires diligent management. Dr. Hussain, could you now review the immune checkpoint inhibitors that are currently approved for earlier stage bladder cancer and highlight the key efficacy and safety findings from the recent phase 3 studies that are shaping the field?
Many thanks, Brenda. Yes, I think these are exciting times. We are seeing a number of trials and um, studies that have really changing and transforming the outcome for our patients. There are drugs which have been FDA approved, and there are some EMA approved indications as well. For example, in terms of the Keynote study, we've got pembrolizumab as single agent. We've got a Keynote 905 in cisplatin ineligible patient population. with Checkmate 274 adjuvant nivolumab, and then durvalumab in perioperative setting in muscle-invasive bladder cancer, and also in non-muscle-invasive bladder cancer is really coming through now. And then atezolizumab with the IMvigor011 data based on ctDNA. So I will just walk you through some of that data. We will just pick few of those studies to really show that how things have changed and transformed. So first one, which I would like to talk about, is the Niagara study, which was a perioperative durvalumab with neoadjuvant chemotherapy using platinum-based chemotherapy, gemcitabine cisplatin. Split-dose cisplatin was allowed in patients with impaired renal functions with GFR 40 to 60, and 20% of those patients were actually with impaired renal function. And it's a big study with over 1,000 patients were recruited in that trial, and it met its primary endpoint, event-free survival, with a hazard ratio of 0.68. And it also met its key secondary endpoint of overall survival with a hazard ratio of 0.75. So these are key exciting changes because these treatments are improving the outcome, achieving more cures, and in a sense, a higher subset of patients are being cured by adding immune checkpoint inhibitors early in that setting. Perioperative durvalumab, in terms of toxicity, what was key is that there was no delays in surgeries because additional durvalumab treatment, both in perioperative and the neoadjuvant setting, didn't lead to any delays in surgery or cystectomy happened on time. So again, that was important because the toxicity related to durvalumab were not any significant, and it was generally well tolerated. Patient received adjuvant durvalumab as well as part of the Niagara trial, and the outcome was really significant, better in the experimental arm, and that has led to FDA approval and EMA approval for platinum-based chemotherapy, gemcitabine cisplatin with durvalumab in perioperative setting, followed by adjuvant durvalumab as well. I think EV-pembro is important to talk about because EV-pembro, as you know, in metastatic setting has been quite a game changer. And here in the perioperative setting, this is a cisplatin ineligible patient population, which has been approved. And on that data, which is really looking very interesting and basically looking at the event-free survival at 24 months, 2 years, significantly better in the EV-pembro arm. And in terms of secondary endpoints as well, moving on to significantly improved overall survival with 0.50 overall in terms of the cisplatin ineligible patient population group. Toxicity is important to talk about because these patients are being cured of the disease as well. So we need to think about long-term toxicities as well. And if you look at the toxicities like neuropathy and things, these are seen in these patients as well. ALT rises were seen, maculopapular rashes and skin toxicity was seen as well. And remember, the skin toxicity of conjugate antibodies are different skin toxicities from immune checkpoint inhibitors. Moving on to the ctDNA guided atezolizumab, again, a very interesting study, phase 3 IMvigor011, which randomized patients between atezolizumab or placebo, 2:1 randomization based on the ctDNA when patient's CT scan was negative. It is based on the IMvigor010, which was a negative trial, which did not show the benefit, but within a subset of patients with biomarker evaluable patient population, we learned that actually ctDNA can help us and be a predictive marker. And IMvigor011 very clearly documents that, and that has led to its approval in FDA approval as well. Safety-wise, again, there were no new safety signals that came through in terms of atezolizumab compared to placebo. In this patient group population, based on ctDNA, there were no additional significant toxicity, so generally well tolerated. Moving on to durvalumab with BCG in earlier disease setting and non-muscle invasive bladder cancer, it met its primary endpoint of disease-free survival and showed a statistically significant and clinically meaningful improvement in disease-free survival versus BCG induction plus maintenance alone in patients with BCG-naive high-risk NMIBC. Again, generally well tolerated, no additional significant toxicities seen, and overall, this was delaying cystectomies and this was delaying recurrences as well. So met its primary endpoint. So really exciting how the field has evolved over the last few years. Now we will answer this challenge question. And here is another challenge question. Diane, how do you think with these new advances we are seeing with your uro-oncology nursing sort of hat on, in terms of the approvals of these immune checkpoint inhibitors, how does it influence the urology team's work to support patients with earlier stage bladder cancer?
Yeah, so as you've shown, that the landscape for bladder cancer is changing, and it's really exciting developments that we've seen with recent approval of the immune checkpoint inhibitors, particularly with PD-1, PD-L1 agents, which are already reshaping how urology teams are managing these early stage non-muscle invasive bladder cancers. Also, the use of these agents, there needs to be a greater collaboration between urology and oncology teams, making sure there's no delay in patient treatment. So, having that good communication with MDT across the pathway, and also with the toxicities, which are different to the standard chemotherapy, just making sure that there's nothing that delays treatment.
Diane, could you walk us through the treatment protocols as these new treatments are marching in earlier disease setting? What are the practical considerations that we need to pass on to our colleagues here?
Yeah, so these are the treatment protocols as you've discussed in the trial for non-muscle invasive bladder cancer and muscle invasive bladder cancer. In muscle invasive bladder cancer, neoadjuvant pembrolizumab can be given with enfortumab vedotin every 3 weeks for 3 cycles. And then in the adjuvant setting, pembrolizumab is given with enfortumab vedotin every 3 weeks for 14 cycles, or pembrolizumab 400 milligrams and with enfortumab vedotin every 6 weeks for 7 cycles, again depending on local protocol. The key thing is to note here that pembrolizumab is administered after enfortumab vedotin when given on the same day. And then looking at the Niagara trial, we've got perioperative durvalumab now being added to gemcitabine and cisplatin. This is given every 3 weeks for 4 cycles. And then post-surgery adjuvant durvalumab, 1,500 milligrams as a monotherapy for 4 weeks up to 8 cycles. And here it's important to notice that the administration of durvalumab is given prior to chemotherapy when given on the same day. Similarly, durvalumab 1,500 milligrams is given every 4 weeks for 13 cycles in combination with BCG induction and maintenance in the non-muscle invasive bladder cancer setting. And again, durvalumab is given prior to BCG if it's given on the same day. And then we have atezolizumab, which is given every 2 weeks, or it can be given every 3 or 4 weeks, depending on local protocol. And this can be given up to a year. So, Brenda, when a patient is about to start immunotherapy, what are the important things that you would like to assess before they have their first infusion?
Thanks, Diane. That was a wonderful overview. So, we're going to be talking about some of those inflammatory side effects that we can see in a little while. So, this is sort of keeping that in mind, that these checkpoint inhibitors can lead to some inflammation, and this can occur anywhere in the body. So, this is why I really try to get a good baseline picture of how patients are before they start treatment, looking at their performance status. So if there were to be toxicities or side effects, is that performance status staying the same, or are they starting to feel some of the side effects are interfering with their activities of daily living? Obviously, height, weight, doing your assessments, vitals, general symptoms. So finding out, are they having diarrhea? All of this at baseline. Are they having shortness of breath? Do they have a cough? What sort of past medical history do they have in terms of cardiac or lung that we should be aware of? Do they have any issues? Are they currently diabetic or pre-diabetic? And then just finding out, basically looking, again, are you having cough, shortness of breath? Do you have tired? Are you tired? Are you having diarrhea? Do you have nausea? Do you have acid reflux? Because if those things were to occur after administration of the immune checkpoint inhibitors, you want to be able to grade your toxicity appropriately based on their baseline. And again, the laboratory tests, there's a myriad of tests that you want to get baseline labs so you can follow if there is liver function elevation, or if they start to develop what we can see most commonly, hypothyroidism. And then your imaging is everything that you can utilize to evaluate and assess your patient's response to treatment after getting it started.
So I think really great overview, both Brenda and Diane. Thank you so much. Diane, one aspect of perioperative immunotherapy that may be less familiar to oncology teams is how treatment is coordinated. So when patients come to our clinic and they're finishing their perioperative neoadjuvant treatment, important is to get them back to the surgical colleagues as well. So just take us through what are the steps that we should be very carefully aware of, and how should we plan so patients are not missed in any way or delayed in this pathway.
Yeah, so this is very important, and the correct timings are essential. So for the neoadjuvant treatment, it's about 12 weeks in total. So the timing of surgery needs to be within about 4 to 8 weeks after the treatment. Over 8 weeks is not recommended, as it wasn't in the trial. And this just allows for the blood counts and kidney functions to recover from chemotherapy, and it allows the patient to get back to their baseline, how they were ready for major surgery. And it allows time for us to control any acute toxicities from chemo or immunotherapy and allow them to resolve. Also, it's a close enough window so the tumour does not have time to grow in that time. And we would do a check CT scan just to make sure the treatment response and that the disease hasn't progressed. And then we allow for a recovery period post-surgery, which would be about 4 to 10 weeks, but on average about 6 weeks. And this allows for wound healing, that they have no bowel issues and there's no ileus post-op. We check the patient's performance status and make sure that any acute post-op complications of them being resolved. And then adjuvant treatment would start between 4 to 12 weeks post-op, and once the patient has recovered.
Yeah, no, that's brilliant. Great overview. I think it's really important. Timing is really key here, that there is no delay in terms of post neoadjuvant chemotherapy and surgery, because these patients can progress. So thank you for highlighting those. Brenda, once patients move into the adjuvant immunotherapy phase, what are some of the key lessons that oncology nurses can share with urology nurses?
So just a basic understanding. We've already seen them for their, neoadjuvant. So just the adjuvant treatment, knowing that this is going to help maximize the best potential response for a curative therapy. And then the fact that they don't have disease, again, just given surgery and what we know about bladder cancer and the staging, providing this opportunity to do long-term therapy is important because we're trying, again, the end goal is response. Um, Patients actually are quite happy to come in and see us, believe it or not. And they're engaged in their treatment. They understand they're going to be monitored intermittently with scans. They understand the importance, revisiting things, ongoing education. And then again, we're seeing them every like 3 or 4 weeks. So we're monitoring for, subtle changes in lab results, or, maybe the patient started to develop a dry cough and, it's like the red flag might go up, that this needs to be monitored more closely. And even if patients tell you, oh, I'm fine, which has happened, going through that whole checklist, that whole review of systems, because even though they think they're fine, you can usually find out something might be happening. And it's better to know about these things ahead of time so you're able to manage them before they become like a bigger, more complex event.
Brilliant. Thank you very much. And now please answer this challenge question. And here's another challenge question for you. Brenda, could you walk us through the spectrum of immune-mediated adverse events that can occur with immune checkpoint inhibitors, and how these compare with other adverse events from other systemic therapies? Because it is so important for the urology teams as these drugs are moving into earlier disease setting, so to make them familiar with them.
So basically, immune mediated AEs can be actually affect any organ in the body, including the endocrine gland, liver, skin, lungs, and GI tract. Fortunately, in my clinical practice, I don't really see that more than one immune-mediated event can occur. So what would this look like? So with endocrine, we're always worried about monitoring the thyroid gland, and also making sure that if patients are having worsening fatigue, et cetera, we include that in the differential. As well as I've seen, even though it's rare, hypophysitis. So thinking about that pituitary pathway. With the lungs, they may develop a dry cough. They could have shortness of breath. And you need to follow up on that quickly, especially if you see somebody who comes in and their O2 sats are going down and they're short of breath. You definitely want to get a CT. Liver can be affected, so monitoring for AEs, especially AST, ALT, total bilirubin. Skin, they can have a rash. It could be like macular papular. What you don't want to see is sunburn like rash. And with the GI tract, you could have nausea, vomiting, diarrhea. So, this is why when I sort of originally talked about these events, is making sure that you know what your patient's baseline is. So, if they become more tired, you're working up to see if it is thyroid versus just fatigue from other sources. Chemotherapy, generally, this is where it can get confusing for patients because they're often already thinking chemotherapy can make them tired. It can cause nausea, vomiting. They might have abdominal pain. They could have shortness of breath. And so I tell them when I'm seeing someone, you shouldn't have so much fatigue you can't get out of bed. You shouldn't be short of breath. You shouldn't have nausea, vomiting, etc. So that way, when they do have an event, they let us know and not just assume that this is what is expected and normal. Diane, immune-mediated AEs can arise at different points during treatment. Given this variability, what practical monitoring strategies can help with the care team identify these toxicities as early as possible?
Yeah, thank you, Brenda. So, when we look at the toxicity, um, as you mentioned, the skin toxicity happens quite earlier on in the treatment, so maybe 3 to 6 weeks. Bowel toxicity, IO colitis can be 4.5 to 10 weeks. But some things like the liver toxicity, pneumonitis, and even nephritis have a more of a later effect, and may not happen for weeks and months later. So the key things here are recognizing and addressing the immune-mediated adverse events early. So again, having the baseline, the symptoms, what's normal for them. As well, if we see patients face to face, we can see if they're breathless or the way they walk in, if they're fatigued. So you're looking for non-verbal clues as well. And the main thing is to educate. So we're educating the teams across the MDT in urology so that if a patient goes to another department, they're also aware of what to look out for. And also what the patient, need to educate the patient and their relatives and their family so that they know that if they're not in the oncology setting, that this could be a side effect of treatment. And then the important thing is to escalate any new symptoms promptly so that they can get the proper treatment.
So I think it's been really exciting looking through these immune-mediated toxicities, and I think it's really important for us to think about different toxicities that occur with different regimens we have talked about. With conjugate antibodies coming into play and making a big impact on outcomes in metastatic urothelial cancer, now moving into perioperative setting, it is important to understand that over the last 10 years, we have learned how to manage immune-mediated toxicities. We have learned better, as you, Diane and Brenda talked about as well, to basically identify these toxicities early, manage these toxicities, and treat them. And that helps us to make sure patients can be re-exposed to those same immune checkpoint inhibitors. With conjugate antibodies, it's a new drug which is coming into from metastatic into perioperative setting. Some of the toxicities like neuropathies can appear late after about 14, 16 weeks of treatment. And it is important because sometimes by the time the patient comes back to you, they may start to have difficulty in walking. They may start to have numbness in the feet. So a lot of these things will be by looking at them, by talking to them, by some of the nonverbal clues that my colleagues Brenda and Diane talked about. They are so important to look at. And I think in terms of these neuropathies, for example, because there can be residual neuropathy for quite, patient can live with that neuropathy. And that is important, that when we move these drugs from metastatic disease setting into perioperative setting, where more patients are being cured, it is important to think about shared decision making, think about toxicities. The toxicity, for example, the skin toxicity of enfortumab vedotin is very different to the skin toxicity from immune checkpoint inhibitors. And that is important for all of us to identify and learn from each other's experiences as well. Brenda, how do you manage immune-mediated adverse events once they have been identified?
The first thing is grading. So, if it's mild or moderate, severe, or very severe. And then also, can the toxicity be managed in the outpatient setting versus do they need to come into the hospital? And so the backbone of managing immune mediated events are to start steroids. And again, depending on the grade, you may be able to treat the patient with oral steroids. If the event is severe, like a pneumonitis or colitis or hepatitis, you're going to want to start them on IV steroids. The steroid treatment, there are guidelines for that with starting dose, how long to keep them on the dose, and when to basically start tapering the steroids. So just these are some really great examples. So for rash, it's covering less than 10% of the body surface area, and patients may have some symptoms, but it's manageable. So again, you could consider starting topical corticosteroids in this point. It wouldn't require oral. Grade 2, a little bit more extensive rash, a little bit more symptomatic. You might want to add in some additional treatments like antihistamines, etc. Now, the other thing I want to just also revisit is when the toxicity is grade 1 or 2, you really don't need to interrupt your treatment. Again, management of toxicities to try to maintain them either a grade 2 or less. In terms of diarrhea, colitis, this can become somewhat life-threatening in a relatively short period of time if not addressed early. So you really want to know, what is their normal bowel regimen and how many stools in addition to their normal bowel regimen are they having? So this will help you, like, are they having 3 liquid stools a day? You could do an antidiarrheal. Make sure they're well hydrated, electrolyte replacement, foods that are high in potassium, magnesium. If they're having more than 4 liquid stools a day, this is when you actually want to start oral corticosteroids, and you're going to want to hold therapy. A grade 3 or 4, again, in the hospital with IVs, corticosteroids. They may need workup from other providers, a colonoscopy, etc. But again, the whole idea is to try to keep them on treatment, keep their toxicities in based on skin less than 2, diarrhea, colitis, less than 1, basically. So I think having this information is handy, so that way when you're seeing a patient, you see that toxicities, depending on the grade and what it is, has different recommendations about keeping therapy going versus, holding therapy and starting more intensive treatment with corticosteroids.
Thank you very much. That's great. Thank you, Brenda and Diane. And now please answer this challenge question. And here is another challenge question for you all. So I think what I will conclude with is that immune checkpoint inhibitors are moving into earlier disease setting. It is really important that we learn how to manage these toxicities and work in a multidisciplinary team setting as things are moving from oncology into much earlier disease setting, into urology. We have moved into muscle-invasive bladder cancer and now into non-muscle invasive bladder cancer. So collaborative approaches are key between urology and oncology teams. Multidisciplinary teamwork is the key, is the buzzword. We need to work together. I often ask my urology trainees to come and sit with me in my oncology clinic, and I send sometimes my oncology trainees and ask them to go and sit in urology clinic. That is how we learn from each other's experiences, and we'll be able to pass on the benefits that we are seeing from all these new treatments and the trial protocols over to our patients, to make sure that these drugs are given safely and effectively and improve the outcome for our patients without compromising on the quality of life as well. Thank you, Brenda and Diane, for sharing your valuable insights, and thank you all for joining us today.
This has been an activity published by Peer Voice.